Okay, so what we're going to do here, what do I have, 45 minutes? We're going to talk a little bit about the differential diagnosis and definitions for syncope, the current typing of syncopes. Because I like to be cost effective, the evaluation will focus in on perhaps a more cost effective, although we might touch on some of the things that you shouldn't at least be thinking of from the get-go. Risk stratification is very important when we talk about syncope. Just going to touch briefly on management. That's not really the focus of what we're going to do today, and talk a little bit about some of the complications for syncope. Okay. I put this slide up here as a reminder, you know, just as all squares are rectangles, not all rectangles are squares, right? The same thing is true for all syncope involves loss of consciousness, but not all loss of consciousness meets the definition for syncope. So, what is syncope? It has to have three features to it. It's transient, typically less than 1 minute, but it might be a little bit longer than that, but it is transient, okay? You lose tone, so if you're standing, you may hit the ground. If you're sitting, you may just slump forward, so you lose your postural tone. Unlike other forms, unless bystanders do inappropriate things, this will resolve spontaneously, and like some of the inappropriate things, we will be trying to stand somebody up that is trying to self-treat their syncope by getting down. And this is one of the key features, it is due to reduced global cerebral perfusion, okay? So decreased blood flow to the entire cortex. So there are certain things, and we'll get into them, why their loss of consciousness is not syncope. Okay, a whole bunch of things we think about when we've got folks presenting potentially with loss of consciousness, and we don't know whether it's syncope or not. I will tell you, it is not always straightforward. You don't know whether they had one of these and then something else, or did they have a syncopal event, and not uncommonly they have head trauma related to their syncope, and so then maybe the loss of consciousness is not quite so transient because we've added a head injury on top of things. So if it were easy, you know, we wouldn't have to have this lecture. So sometimes. So there are some things that can present. For example, seizures, you can have transient loss of consciousness with that, but it's an electrical disturbance. It isn't a perfusion problem. Obviously, people pass out from intoxication. That's substance related. That is not due per se necessarily to a hypoperfusion event. People often want to go down the cerebral vascular pathway. Did they have a stroke or TIA? That would be a localized hypoperfusion, not a global hypoperfusion. So if you're really thinking, you know, more in that category, it has a whole different workup, etc. So you can look through a variety of things. Falls, you can just have a mechanical fall, and again, as I mentioned, anything, and perhaps they injured their head, and then we don't get the entire story, so we can't detail it. Functional, kind of psychiatric. Metabolic. Hypoglycemia, you know. Have people passed out from hypoglycemia? Yeah, that's not syncope. That typically requires an intervention, right? You have to get some kind of glucose into them to correct that so it's not spontaneously resolving. So think about those kind of things. Hyperventilation, you pass out because you've gotten your CO2 too low. That is spontaneously resolving, but it's not due to global hypoperfusion. So you think about a variety of those things, that these may be confusing when somebody first comes in, but that's what we're trying to tease out. And it has to do with a lot of the consequences, if it's true syncope, and we'll get into why we risk stratify, etc., versus some of these other entities, which may also have significant potential sequelae. Obviously, if you've had a stroke, it's got significant sequelae, but and morbidity, etc., mortality risks associated with it. But we want to know what to do when somebody presents to the emergency department of the hospital and we think they might have syncope. So you have to have a sense of what it really is, what it could be that's not syncope, and we'll go from there. So currently, they break it down into 3 different categories of syncope right now. So the classic is your neurally mediated reflex syncope is another way it's caused. Orthostatic hypotension or orthostatic syncope is another one. And then cardiac syncope. Those are the big 3 categories. Cryptogenic is on here, and I'm not going to talk about that per se. That just means we haven't found out the underlying etiology potentially, so we can't say whether it was really syncope, whether it was one of these 3 types that just at the time we diagnosed them with that we didn't yet have a diagnosis. So, all right. So you're neurally mediated. It is considered the most common, and particularly you'll hear about the classic faint. And the mechanism is you have simultaneously decreased sympathetic vascular tone, so your vessels are going to dilate. While that's happening, you get increased vagal tone, slowing your heart rate down. So 2 mechanisms to reduce your cerebral perfusion, and down you go. Okay. A comparable one is the carotid sinus syncope, and it involves mechanical manipulation, like of your carotid bodies and things like that, that alter the sympathetic and parasympathetic tone. So knowing that's one of the things as you're doing your exam and your histories, you'll be thinking about some questions you would ask related to that. Orthostatic syncope. Obviously, the main contributing things that we think about with that are they volume depleted for any reason whatsoever. So anything that could cause the volume depletion could be a cause. Somebody's bleeding out, somebody's been out in the heat and has sweat off 6 liters of sweat, whatever, vomiting, diarrhea. You've got that to think about. Medications, right? Highly common. You have to think about it. It's a whole host. They can be even potentially in common medications that you don't think about, but nevertheless may be contributing in a given individual. So there's some common ones that you're going to think about, all the antihypertensive, diuretics, etc. So always review medications. A whole host of things that are going to give you autonomic dysfunction, be it diabetes, which we of course are going to see quite commonly. Is it from HIV, neuropathy, whatever. So anything that can be associated with decreased autonomic tone that will result in an orthostatic syncopal event. Cardiac syncope, and as you'll see as we get into this is the one that we're really most concerned about because this is the one that has the highest morbidity mortality risks associated with it. So this is the main reason that when somebody comes to the ER says, no, you got to admit them. Okay, so we'll talk about that. Clearly, arrhythmias, be it tachyarrhythmias or bradyarrhythmias, can lead to a syncopal event. A variety of structural cardiac processes, whether it's a stenotic aortic valve, for example, whether you've got tumors plopping into your outflow tract, if you've got hypertrophic outflow obstruction, so something associated with that. In addition, of course, some of the structural conditions such as the cardiac hypertrophies might have an increased risk of VTEC, for example. So it could be multifactorial in a cardiac point of view. One of the things that is getting a little bit more press from the syncope literature and the ER literature is listed under here under the other rare causes, pulmonary emboli in some cross-sectional studies and people that have been worked up and they may even have a presumptive other diagnosis for the cause of their syncope. Some evidence says 13 to 17% of those people may actually have had a pulmonary embolism as the cause of their syncope. We used to say, Dr. Casper and I, we used to say, oh, you're never going to see syncope from a pulmonary embolism. Well, I've, of course, seen a number since that started happening. Part of it, you think about it, it's a transient obstruction potentially impacting the cardiac output, leading to a transient global hyperperfusion. So besides the PEs that we have to think about, rare things would be like a cardiac ischemia, aortic dissection, Steele syndromes, the people that pass out because they're working over their hair, brushing their hair, working over their head. The subclavian Steele syndrome can lead to siphoning off of flow, thus leading to global hyperperfusion. They quit using their arms over their head and then they'll recover. There is an age-related prevalence, if you will, of the underlying causes of syncope. As you can see in the under 40 crowd, the vast majority, about 90%, are neurally mediated syncope, and that decreases, but still quite common. It's still the majority. Here you're still a little bit over 50% when you're evaluating patients who are over 60 years of age. But as the patient's age, you get progressively a higher percentage of orthostatic hypotension as a cause of syncope, arrhythmias, and then actual cardiac structural disease becomes more prevalent with increasing age. So we think about that as we decide our risk stratification, etc. Okay. So again, we're going to be cost effective, and I tell people almost anyway, if you do a good history, even separate from your physical examination, if you do a really good history, you've got a 2/3 to maybe as much as 80-90% chance of having the main process from your history alone if you're able to get a decent history. Well, we know the workup of syncope, we're going to get the etiology and 1/3 to 2/3 by our history and physical alone. It will help us with the risk stratification that we are going to talk about. Witnesses are key. If you can get a witness, you need a witness, because the patient may have had, like I said before, a head injury as part of the event. They may not remember all of the details. There are certain questions that we could ask that will lead us to, is this syncope, is this a seizure, etc. All right. Medications, are they arrhythmogenic medications? Are they electrolyte disturbance medications? Are they hypoglycemic medications? Are they meds that are going to cause them to be orthostatic? So you have to have a detailed medication history. You clearly want a history of sudden death in the family. Okay? You're not just talking about, does anybody have heart attacks? You want to know about sudden death in the family. And particularly if somebody is younger, you want to know that, because normally you're going to, just by the nature of their age, you're going to consider a young person probably low risk from a cardiac point of view. But if they've got a positive family history for sudden death, you're going to look into that further. Okay. We've kind of described a variety of underlying medical conditions that might give them a reason to have a syncopal event, be it orthostatic, such as in a diabetic with autonomic neuropathy, a Parkinson's patient, someone who has known GI bleeding, for example. You know, they've had previous episodes, so maybe they are having orthostasis from their volume depletion from their acute blood loss. So just as always, you're going to be the comprehensive internist and do a complete history of what is their pertinent past medical history, right? With respect to the event itself, there are 5 Ps that we want to explore, because they can lead you to thinking this is more neurally mediated, this is more orthostatic, it makes me more concerned that it is a cardiac kind of syncope. So of the 5 Ps, did they have a prodrome? Were there any precipitants of the event? What position were they in when they had the alleged syncope? Did they experience any palpitations? And there are certain post-event questions that we want to ask about. So, of the prodrome kind of questions. Did they have any sensation whatsoever that this was about to happen? Oh, I got lightheaded, quote, dizzy, blurred vision. I tell all my team members, dizziness is a layperson's term. When they say dizzy, it is your job to ask the questions to determine, is this patient describing orthostatic type of symptoms to you? Is it a lightheaded version? Are they vertiginous? They only are dizzy when the lights are out, suggesting that they have no position sense. And I call the fourth kind supratentorial, that you can't make heads or tails of it, maybe because they have a psychiatric story behind them. But dizziness is a lay term, so you be sure you delineate it as best you can when you're obtaining the history. But if they have those symptoms, they might have the neurally mediated or orthostatic version of syncope. Did they have the classic prodrome, nausea, sweating, cold, clammy kind of feeling before things happened? If they had zero prodrome, no warning whatsoever, that actually can be a way elderly people present with a neurally mediated, but it is more concerning for a cardiac cause of syncope, the total absence of a prodrome. Precipitants. Were they getting ready to give their first grand rounds? Were they in a warm, crowded environment? Were they afraid because somebody's coming at them with a needle to draw blood from them? Those kind of what happened right beforehand. So you can tease that out. Were they commonly, for example, in our elderly, we have situational syncope. Were they on the toilet? Were they coughing? So what were they doing when the event occurred? And you can see here that can point you to one pathway versus another. Head movement, tight collars. I remember one when I was a resident. We had a gentleman, he was sitting at the kitchen table playing Scrabble, and he had both of his fists up under his chin, leaning down, and down he went. So he had a carotid sinus type of syncope. So you want to know what they've been doing up in their neck area. Very concerning. Did they have a syncopal event during exercise or zero risk or supine? Well, I'll get to supine in a minute, but no obvious precipitant. You worry more about cardiac arrhythmia or structural heart disease. The classic, I've been holding the retractors in the operating room for whatever, I can't move, I'm uncomfortable, and all of a sudden I'm going to start getting cold and clammy and sweaty. So have they been in prolonged standing, pooling of blood in their legs? Sudden changes in postures obviously make us think about orthostatic. If the syncope occurred while they're already supine, that's worrisome, right? Arrhythmia or structural heart disease. You ask the patient if they experience any palpitations. Clearly, if they had palpitations, we're thinking that an arrhythmia could have been part of the event, and we would take that seriously. Oops, I left off the post-diagnostic one, or some of the post things. I don't know why I left that off. You want to, I'll go up here, ask what was their consciousness like right after the event? Did they pretty much perk up right away? Or were they confused for a bit, like a postictal person might be? Clearly we asked, did they have any incontinence? If there was a witness, was there any jerking? However, just so that you know, any type of syncope can have like 4 to 5 beats of myoclonic jerk. That does not automatically mean the patient has had a seizure. All right, it needs to be longer than that. They need to have had, like I said again, signs of a postictal state, something that distinguishes myoclonic jerks with a syncope from a true seizure event. All right, okay. With your physical examination, of course, you're going to be worried about their vital signs, and we attendings tell people over and over and over and over again, get orthostatics, and they're easy for you to do. You do not have to delegate that to nursing to do at their leisure. You're seeing them down in the ER, you got a monitor right there, they got a blood pressure cuff, all you got to do is hit a button. So do it lying, do it standing. Ideally, there'll be a couple of you there in case you need to rapidly assist the person back down if they are clearly precipitously dropping their blood pressure. But it's easy to do. You will get it done faster and before a lot of interventions are done. So please do that promptly. You do want to check the carotids out as much because you might do another test later. If you think that a person has a TIA or a stroke, obviously you're going to focus in on that. But typically that by itself is not going to be revealing for a syncope unless, for example, you're hearing murmurs that are radiating up to the carotids, for example. But we do want to rule out obvious bruits before we jump down a little bit later and perhaps do our carotid sinus massage. Anything that's going to help you with either diagnosing syncope or these common non-syncope things, do they have murmurs? Do they have arrhythmias on examination? Do they have a tender abdomen suggestive that they might have had a GI bleed? Are they, significant respiratory distress that might make you go down a different pathway, for example? I did want to talk a little bit about the carotid sinus massage because there's actually some strong evidence that that is an appropriate part of a syncopal workup, and we usually will do that after the initial workup is negative in patients over 40 years of age. So the way that you do that, they need to be on telemetry, so you can be monitoring that. And again, it's better if you've got where you can be doing some automatic blood pressure. You're really supposed to do it in both the supine and the standing positions. And you massage one carotid for 10 seconds, then go to the other one for 10 seconds. Obviously, you don't do both at the same time. That would be bad. And what you're looking for a positive test is if they develop asystole for more than 3 seconds, that would be positive, or if their systolic blood pressure drops by more than 50 millimeters of mercury. So I don't see that we do that necessarily a whole lot, maybe not as much as we should, but it does have strong supporting evidence as part of the workup for syncope. So maybe we just need to practice that a little bit more often. Okay, so we'll just start with a quick flow. You've got somebody shows up to the emergency department. They've had this transient loss of consciousness. You suspect syncope. Obviously you've interviewed witnesses and done some beginning physical and history and maybe even some beginning labs, and you think it's non-syncopal, and you go down, oh yeah, they were hypoglycemic, we treated that, and then move on. If you're not sure if they have syncope, we'll go down this pathway to the uncertain their diagnosis. We'll do risk stratification. Low risk, single episode, they really don't need any further interventions. Like, this was an early mediated, they were just stressed and they'll be fine, nothing to worry about. Not sure, then we actually might want to do some additional testing. This one might be a time where you're going to do your carotid sinus massage. You're going to look at your electrocardiogram for other hints, things that will help us determine, in fact, that they are a low risk person. If we think they are high risk, we're going to admit them at least for observation and go down that pathway. Obviously, again, if we know they had syncope for a certain specific reason, you diagnose that and treat it. Okay, so if somebody presents with the classic faint, that's usually a benign situation. It may not be in the elderly, though, partly because of their risk for the complications from even a simple syncopal episode. And orthostatic hypotension as the cause is usually benign, but again, depending on the etiology of why they have orthostatic hypotension, the underlying etiology of that actually increases their mortality. So again, you're thinking typically in that group, the older person or persons on medications or something that may or may not be modifiable. Cardiac syncope has a concern for high mortality across the age spectrum. So that's the one we really are trying to identify. So these are people obviously you're going to admit if you suspect that they have significant structural cardiac abnormalities. You know they've got a low EF, they've had a previous MI, you've done your basic screening labs and they've got a significant electrolyte disturbance or anemia, or the history and exam that you have suggests that they might have had an arrhythmic event. So what, with our high-risk syncope, if we in fact determine or suspect, and it gets down that pathway of cardiac syncope, there's actually a 6-month mortality rate of 10% due to the underlying etiology. So that's why we admit these people, because we want to make sure we're not missing one of these. So things that you really want to identify if they have them. Is the syncope exertional? Did it occur when they were supine? Did they have precipitating sensations of palpitation before the event? Do they have a personal family history of sudden cardiac death? Obviously, if they have a personal history of sudden cardiac death, I hope they already have a defibrillator in place. Have we identified non-sustained VTAC? Significant conduction abnormalities on the EKG would be very worrisome. And other high-risk things, obviously, chest pain, heart failure, unprovoked syncope with no warning, hemorrhage, and frequent recurrent episodes would be a reason to admit. Okay, there is actually a nice guideline evaluation of guidelines in syncope study, and they're trying to focus in on some factors that help identify who's at a high risk for cardiac syncope. So it's a scoring. So if they have palpitations preceding the syncope, you give them 4 points. If they have known heart disease, an abnormal EKG, or both, they get 3 points. If it was an exertional syncopal event, also 3 points, while supine, 2 points. You actually subtract points if it acts more like a classic neurally mediated with obvious precipitating factors like the needle was coming after me, or I was dehydrated, or they had typical prodromes. You subtract some points. So there's a 77% likelihood that they have a cardiac syncope if their score is 4 or higher, and you can read this. And over the subsequent year and a half to almost 2 years after one of these events, individuals who score 3 points or higher have a 17 to 21% mortality in that time frame. Okay, and you can see the values obviously drop 2 to 3% if your score is less than 3. So this can be helpful to decide whether a person needs to be admitted or not. So you can use this scoring system. Okay. If someone has a syncopal event and they don't hit their head, and you examine them and they don't describe any neurodeficits, and you don't elicit any neurodeficits on your physical examination, CT is pretty worthless, okay? If you're not thinking that, oh, I'm getting a thumbs up for that. So it's pretty worthless. Clearly, if you're thinking they had a TIA or something else, you're doing a different workup. But if you're doing the CT scan for syncope, it's a low yield unless you found something localizing, okay? Or they sustained a trauma due to the event. Carotid Dopplers are worthless for syncope. If you're going down that pathway, you're telling me you're thinking this person had a TIA or a stroke. Don't order carotid Dopplers for syncope. In the absence of symptoms, you don't need to do cardiac enzymes. Now, I say the absence of symptoms, you do need to be careful. For example, not everybody is the standard male who's 45 or 55, whatever age you want, with a crushing chest pain. Remember, they're not the majority, right? So women, diabetics, they may have the nausea and epigastric, some other symptoms that might even have been part of their prodrome, right?
So if you have the right scenario, you might want cardiac enzymes. So it doesn't have to be a head-crushing chest pain to get that. But in general, cardiac enzymes are not helpful in a syncope workup. Similarly, tilt table is not helpful for the vast majority of syncopes. This is typically going to be reserved more for people who have either frequent episodes. Sometimes it helps us with individuals who may actually have a psychiatric process that's contributing to their presentations, or sometimes it's helpful in certain high-risk occupations where they actually have to be absolutely certain of what their risk is going to be, so whether they can go back to their usual job. Okay. Why do we do electrocardiograms? We do electrocardiograms because they are widely available and relatively cheap. Okay. Let me see if can't remember if yeah. I'll get back to that. So electrocardiogram, it can be helpful for our risk stratification. There are times, we'll talk about when we would want to do prolonged EKG monitoring. Echocardiogram if we suspect structural heart disease, and under certain special circumstances we will want to send them for an EP evaluation. Okay. So EKGs, the biggest reason to do them, they are low cost and widely available. Any ER you go to, even most offices, you can get electrocardiogram. They are very low yield, so their sensitivity is very low. But if you find abnormalities on the EKG, that increases the chance that this was a cardiac syncope. All right, so you're looking for signs that might imply a person would be arrhythmic prone or had prior MIs, etc. Okay, so we use it for risk stratification. Prolonged EKG monitoring pretty much are going to be people that have some structural heart disease, have a family history of unexplained heart death, and you didn't pick it up in the initial admission where they had their telemetry for their 23-hour OBS. You would consider this for people with exertional syncope or supine. Abnormal EKG, not necessarily by itself. You'd have to figure some other things out. And if they had a sudden onset of palpitations followed immediately by syncope that you were not able to pick up the etiology with a shorter period of electrocardiographic monitoring. Okay. I'm not going to dwell on this a lot. Obviously, we do the inpatient telemetry. If you truly are concerned about an arrhythmia and you didn't pick it up, we can send them out on a Holter monitor, but remember, that's only good if their episodes are frequent enough, because the Holter is a relatively short term, 24, 48, 72 hours kind of thing. There are a variety of event recorders. Some, like a looping recorder, will include a few seconds before the event. Post-symptom event recorder, it does not actually detect the pre-event. The advantage of that one is it doesn't have any electrode leads, so people would consider that safer, more comfortable to carry around. I actually had a cousin of mine not too long ago who had one of these implantable loop recorders. He passed out while driving. Fortunately, his wife got him to the side of the road, and they could not figure out why he passed out. So that they actually, it's like your pacemaker. They insert under the skin the recorder, and you have it with you, and away it goes. So there are certain circumstances where you would want that. Clearly, these you're going to have a cardiology involved typically, because you're concerned about more than neurally mediated or orthostatic type of syncope. On clinical examination, if you're suspecting valvular heart disease, you would want an echocardiogram if there's a possibility that they could have an outflow obstruction. So, for example, in our younger people, you're doing their sports physicals. Part of that, you're supposed to have them squat and all that kind of stuff. You're trying to elicit a murmur. And if you find one, you're supposed to proceed down that pathway. I've never had a patient with an atrial myxoma, but they do exist, and they might have that plot. So
Other types of cardiac tumors might be present, so an echo would be helpful for that. Definitely, we've had people with pericardial tamponade, and usually you're going to have some sense of why they have that based on your history. And if we can persuade people to check their pulsus peridoxus, you might even be able to diagnose that on your examination before you get your echocardiogram. But that is potentially a cause of syncope. Dissection, again, normally those aren't going to be coming to us unless we've all missed it until they've come to us. But an echo clearly can help diagnose that. And a few people in our younger population, we might pick up congenital anomalies for their coronary arteries that can actually have led to an ischemic syncopal event. Okay. I'm not going to dwell on this, just knowing that our EP individuals will be able to do more sophisticated testing for us. For individuals we suspect have some of these either congenital syndromes, channelopathies, that sort of stuff, partly because not only they're going to be the ones to diagnose it, they will also be the ones to help put in the defibrillators to help manage them. Okay. So of the things that we commonly see, you know, you have a person who maybe gets, quote, vasovagals frequently. You can teach them, and some of these can be like your autonomic dysfunction people. You can teach them to do certain things such as the leg crossing, the hand gripping, things like that to increase their vascular tone, squatting, tensing, because you're actually trying to get them, if they're starting to get a prodrome, they might be able to avert the actual syncopal event, so those non-medication things. You know, until in the not horribly distant past, we used to recommend beta blockers for these types of syncopal events, but not anymore. Orthostatic hypotension, clearly meds, check all their medications over and over again until you're sure. They may be folks that we need to really stress and specify you need to drink this amount of water or fluids per day. Elderly people particularly, they may get dehydrated very easily because they've lost their thirst mechanism.
Do you encourage higher salt intake?
Do I encourage higher salt intake? I'm not opposed to higher salt intake, so it's one of those balancing kind of things. If you've got somebody who is a classic neurally mediated, we may use medications that do just that. You know, your flurdocortisone, that sort of stuff, the mechanism is on the same pathway. It's basically increasing your sodium, whether it's through urinary retention, etc. So, yeah, you need to keep that in mind if there's not a reason not to do that. And if there was, then they've got a multifactorial process going on, and it would be a potentially balancing thing. One of the things, you know, if you want to think your patient needs, like the mask trousers, the anti-gravity suits, there is evidence that just putting an abdominal binder on them for autonomic dysfunction as the cause of their orthostatic hypotension is as good. So it's a very beneficial thing that we don't necessarily think about to help manage, and easy to do. They put it on before they get out of bed, and gets good relief for many people. If they have carotid sinus hypersensitivity, they actually probably need a pacemaker. It's similar in regards to some of the people with the tachybrady. They can do that from messing around with their carotids, but they induce a nice asystole, and it's good to have a rescue path with their pacemaker in place. All right. Not only is syncope a concern if you have a cardiac syncope, any type of syncope can have some risks associated. Younger people tolerate it a lot better, obviously, because they bounce back from everything, but it can lead to automobile accidents, fractures, significant lacerations, head contusions. I've had people pass out on and then hit their head on concrete floors, and you can get a intracranial hemorrhage from that. So they can have significant impacts even if they are not
cardiac syncope. They're more concerning if they are frequent. They can impact the patient's quality of life. They may not be able to be gainfully employed in the area that they wish to be, so it has vocational implications. Clearly has implications for driving. We don't want these people out on the road if they have frequent syncopal events that we haven't been able to stop. So might stop you from flying or scuba diving. So okay. So in summary, we will remember that not all transient loss of consciousness is syncope. So you have to think about your differential diagnosis. You want to think about your 5 Ps as you're trying to delineate, was this really syncope? And if so, what of the 3 types do I think it was most likely to be categorized in? Reviewing all medications, both from a syncope point of view as well as a differential of other things that might have been the cause of this transient loss of consciousness that weren't syncope after you've done your evaluation. Cardiac syncope has a high associated mortality. That's why we think about that greatly, and that's why a good percentage of these who present to the emergency department get admitted for observation. And lastly, even non-cardiac syncope can result in injury or reduced quality of life.